Good morning. We're about to begin. Raise your hand if you're able to hear me clearly. Okay, that's good enough. This morning we will be continuing with medical emergencies. And we're going to start with cardiovascular emergencies, which, like respiratory emergencies, are quite common, especially in Jamaica. Introduction. Cardiovascular disease has been the leading killer of Americans since the 1900s. Accounts for 1 of every 3 deaths. In developed countries, it is common for cardiac arrest to occur in the home setting or at home. So 80% of cardiac arrest occurs in the home. If the country has a developed EMS system or pre-hospital response, the survival rate is 80%. So survival rate is actually 80%. Now, if CPR is done prior to EMS arrival, the patient has a 50% chance of surviving. It doesn't mean that the patient will survive, it just means that they have a 50% chance of surviving. That's if CPR is done effectively. But the data suggests that only 8% of persons who go into cardiopulmonary arrest within a country that has a good EMS response system will survive. So based on those numbers and statistics, the survival rate in Jamaica would be far less than that 8%. EMS can help to reduce deaths by encouraging healthy lifestyle, early access to medical care. If we have more persons trained in CPR, that would help a lot. So CPR training for lay people, increased use of evolving technology in dispatch and cardiac arrest response. So as the technology evolve, we need to be utilizing that technology, like compression devices, rescue pod, which gives you information regarding perfusion of the patient, feedback devices that tells you how deep you're going with your compression. So as if we're utilizing the technology as it evolves, then we'll get better responses for cardiac arrest. EMS can help to reduce deaths by public access to defibrillation devices. So in heavily populated areas, if AED is available, that's a plus. Recognizing the need for advanced life support. So CPR is not just chest compressions, ventilations, and using an AED. There is a pre-hospital advanced cardiac life support component. So advanced life support plays a very important part in treating a patient in cardiac arrest. Unfortunately, advanced life support is not available in Jamaica, so the patient won't get any ACLS until they arrive at the most appropriate hospital. The use of cardiac specialty centers when they are available. Now, let's review the anatomy and physiology quickly. The heart's job is to pump blood to supply oxygen-enriched blood cells to tissues. It is divided into left and right sides. The left is the high pressure side, the right side is the low pressure side. One-way valves keep blood flowing in the proper direction, and there are two valves. There are four main valves that you need to be familiar with within the heart. The pulmonic and the aortic valve and the mitral or tricuspid and tricuspid valves. And the valves are present to prevent the backflow of blood in the wrong direction. The aortas, which is the body's main artery, receives blood ejected from the left ventricle, which is the largest chamber of the heart because it does the most work. Now, the heart has an electrical system that controls the rate and coordinates the atria and ventricles. And the first control system is the SA node. SA node or sinoatrial node. This is the main pacemaker of the heart. And where the electrical impulse originates from. Right? So the SA node is the main pacemaker. And the electrical network of the heart consists of the SA node, AV node, bundle of His, right bundle branch, left bundle branch, Purkinje fibers, and then the muscle cells. So it's SA node, AV node, bundle of His, right bundle branch, left bundle branch, Purkinje fibers, cardiac cells, cardiac muscle cells. And the pacing rate for the SA node is 60 to 100 beats per minute. So that's where the normal pacing rate comes from. And this is what gives the heart a rhythmic and contraction. Right? This is what gives the heart a rhythmic contraction. If something is wrong, so if something is wrong with the SA node, then the AV node will take over. So the current moves from the SA node or sinoatrial node to the AV node or atrioventricular node, and then it slows down. So it slows down as it moves to the AV node, and it goes to the bundle of His, goes to the right bundle branch, which is the right side of the heart, left bundle branch, which is the left side of the heart, to the individual fibers to the cardiac muscle cells, then we get what is called a rhythmic controlled contraction. But if the SA node is not functional, so if the SA node is not functional, the AV node or atrioventricular node will take over, and the pacing rate for the atrioventricular node is 40 to 60 beats per minute. So the AV node has a pacing rate of 40 to 60 beats per minute. Now, as you can see, the sinus node pacing rate is 60 to 100, but when it goes to the AV node, it starts to slow down. Why is that? That's something for you to think about. If you have a response, you can type it in the chat, or we can discuss it after break. So why is it that the impulse is slowing down? Very important. Now, if the atrioventricular node is damaged and can no longer function effectively, then the bundle of His will take over. So let's remove the AV node because it's damaged. If that is not functioning effectively, then the bundle of His will take over. That has a pacing rate of SA node is 60 to 100, AV node is 40 to 60. The bundle of His is 20 to 40 beats per minute. So the bundle of His pacing rate is 20 to 40 beats per minute. Now, from the SA node to the bundle of His, regardless of how fast the impulse is moving or how fast the heart is beating, right? So whether it slows down or it maintains the 60 to 100, once it's moving from SA node, AV node, or bundle of His, the impulse can still reach the right side and left side of the heart at the same time and create a rhythmic contraction, a coordinated contraction. Very important point I just mentioned. So let me repeat it again. Regardless of where the impulse is coming from, whether it's the SA node, AV node, or bundle of His, once it's coming from any of these three areas, the impulse can still move to the right side and left side of the heart at the same time, and the cells contract at the same time, or it's coordinated. Now, in other words, the bundle of His is the link. So that is the link, an important link between the right side of the heart and the left side of the heart. If something happens to the bundle of His, so if the bundle of His can no longer regulate the heart, right? So the SA node fail, AV node fail, bundle of His take over, and the bundle of His fail. if that occurs, we now have a connection that is broken between the right bundle branch and the left bundle branch. So there is no longer a connection between the right bundle branch and the left bundle branch. Let me enlarge that. Good. So the right bundle branch is the right side of the heart. Left bundle branch goes to the left side of the heart and to the individual fibers on that side and the cardiac cells. Now, think carefully. If from the SA node to the bundle of His, we can get a rhythmic contraction. The only difference is the beat slows down with each area to the right side and the left side of the heart so that there is a coordinated contraction of the cells. If the bundle of His can no longer function, what do you think is going to happen to the cells on the right side of the heart and the left side of the heart? Can somebody answer that question? Any takers? All right, no takers in the interest of time. Mr. Washington, mic working?
Yes, sir.
All right, so you've heard the question.
Yes, sir.
The bundle is can no longer send impulses to the right or left side of the heart. What is going to happen to the cells on the right side? What is going to happen to the cells on the left side?
So you did a my internet did break a while ago, so you was breaking up. You can repeat?
Can I repeat what?
No, I don't hear the full question that I said a while ago, sir. It was breaking up.
I said the bundle of His can no longer send impulses to the right side and left side of the heart.
Yes, sir.
What is going to happen to the cells on the right side? What is going to happen to the cells on the left side?
Sir, they won't get any information, sir, and they would slow down.
Okay, that's your response?
Yes, sir.
All right, I hear you.
Yes, sir.
Mr. Jones, present or absent? Do you have a mic? Quickly.
Present, sir, present.
Go ahead.
If the bundle of His is no longer working correctly, the impulses will not be sent out to the left and right bundles, and the cells will not contract in unison. So we will get an irregular contractions. That's my take on it.
All right. All right, that's good. So I don't think I need to go any further than there. So you would be correct, Mr. Jones. That is what is going to happen. So if the bundle of His cannot send the impulse to the right and left at the same time, what is going to happen is the cells on the right side of the heart and the cells on the left side of the heart will try to create their own current. So we are going to get chaos, right? They are going to try and generate their own current to move. And that is what is going to create something that looks like this. So this waveform that you see up here, we call that fibrillation. So the heart is going to start to quiver or fibrillate. The issue with this fibrillation is the movement that is occurring is not enough for the heart to fill and circulate blood. So the patient will not have a pulse. So this is your patient in cardiac arrest now. What does this patient require? So for the persons that have completed CPR, I'm certain that there are some persons who have done CPR in the group. What does the patient require at this point? Go ahead, floor is open. Don't let me have to call on persons. You know yourself. Go ahead, Miss Carr.
The person would require a defibrillator, sir.
Person doesn't only need a defibrillator. But yes, that is part of the answer. Patient requires two things at this point. Anybody else? Go ahead, Mr. McCoy.
I think you'll have to start compressions, chest compression.
Only chest compressions?
No, and oxygen. You have to.
Okay.
You have to.
All right. Thank you, Mr. Who was that? Mr. Facey. So this is what the patient needs now. Patient needs CPR and the use of an AED must be incorporated into that. And the patient will need advanced cardiac life support. So it's not just CPR and an AED. The patient is going to need ACLS as well. If they don't get ACLS, they can't survive. So CPR alone and the use of an AED doesn't grant the patient the best chance of survival. They will need ACLS intervention or interventions. Now, the purpose of the AED and CPR, so CPR will mimic the circulation of the heart. The ventilations will push oxygen into the body. So the ventilation is mimicking respiration. The compression is mimicking the circulation of blood. So this will buy time until an AED, automated external defibrillator, is available, and the AED will deliver a shock that creates a flat line. So the AED is going to deliver a shock that is greater than defibrillating current. So you're basically stopping the patient's heart with the AED completely, right? So when the patient is in cardiac arrest, the heart is actually moving, it's quivering, it's just not effective. So the AED delivers a current that is greater than the current that the heart is trying to generate, and it puts the heart into asystole. So you're stopping that current with the hope that this will occur. So this is what we want. Right, so you want a normal heart rhythm to return. So we want the SA node to take back over the primary electrical stimulation. The SA node might not take over, but that is the objective. Deliver a current that's greater than the fibrillating current, put the heart in asystole, and hope that the SA node or sinoatrial node will take over. So that's the electrical conduction system of the heart. So what you need to take home from all of this information: one, the primary stimulus electrical stimulus comes from the sinoatrial node. So that's 1. 2, then it goes to the AV node or atrioventricular node. 3, it goes to the bundle of His. Then it goes to the right bundle branch, which is the right side of the heart, left bundle branch, which is the left side of the heart, the individual fibers or Purkinje fibers, and then the muscle cells, cardiac muscle cells. And then we get a rhythmic contraction. The SA node has a pacing rate of 60 to 100 beats per minute. AV node is 40 to 60. The bundle of His is 20 to 40. And you have a question to answer when we break. Why is it that the impulse is slowing down as it moves? So think about that. Now, if the SA node is not working effectively, AV node takes over. If the AV node is not working effectively, bundle of His takes over. The bundle of His is not working effectively. The link between the right side and the heart, the right side of the heart and the left side of the heart is severed. And then the individual cells will start to generate their own current, and we get fibrillation, ventricular fibrillation. This quivering movement is not effective to generate a pulse, so you will not feel a pulse with ventricular fibrillation. And this patient would not be breathing. The patient will require CPR, the use of an AED, and early advanced cardiac life support to give them the best chance of CPR. So everything has to be early. Bystanders need to start CPR immediately. EMS needs to get there quickly. BLS care needs to be initiated at CPR with the AED, and then ACLS must be initiated as well early, and the patient will then need early definitive care. Now, what the AED does is it's going to deliver a current that is greater than what the heart is generating, creating asystole, and then we hope that the SA node will take over. That might not happen all the time, and we may have to, well, not you, but advanced practitioners, paramedics and higher, will have to push epinephrine to try and get a jump start from the heart. And if the epi works, then we sustain that effect by giving an infusion. So that's that. All right, so the heart's electrical system controls heart rate and coordinates atria and ventricles. Automaticity allows spontaneous contraction without a stimulus from a nerve source. If impulses come from the SA node, the other myocardial cells will contract. No impulse arrives, the other cells are capable of creating their own impulses and stimulating a contraction. So that's unique with the cardiac cells. As long as they can absorb the electrolytes that they need, it will move. So if you put a heart in a solution with electrolytes and it can absorb the electrolytes that it needs, it will move without any control, outside controlling mechanism. It's a unique property to the cardiac cells. So be familiar with your electrical conduction system. Pacing rate for SA node, 60 to 100. AV node, 40 to 60. Bundle of His, 20 to 40. And that's the connection to the right bundle branch and the left bundle branch. If that is gone, individual cells will try to generate their own electrical current and we get chaos or ventricular fibrillation. The autonomic nervous system controls involuntary activities. The ANS has two parts. You have the sympathetic nervous system, which is the fight or flight, and you have the parasympathetic nervous system, which is the one that slows down body functions. The myocardium must have a continuous supply of oxygen and nutrients to pump blood. Increased oxygen demand by the myocardium is supplied by dilation, widening of coronary arteries. Stroke volume is the volume of blood ejected with each ventricular contraction. The coronary arteries are blood vessels that supply blood to the heart muscle. Coronary arteries start at the first part of the aorta, and you have the right coronary artery and the left coronary artery. The arteries supply oxygen to different parts of the body. Right and left carotid, brain. Right? Right and left subclavian, upper part of the body. Brachial, that's in the arm. Radial and ulnar, that's in the forearm. Right and left iliac, pelvic region. Right and left femoral, lower extremities. Anterior and posterior tibial and peroneal, that's in the legs. Arterioles and capillaries are smaller vessels. Capillaries connect arterioles to venules. Venules are the smallest branches of the veins. Vena cava return blood to the heart, and you have the superior vena cava and inferior vena cava. Not new information. The blood consists of red blood cells, which carry oxygen, white blood cells, which fight infection, platelets, which help blood to clot, plasma, which is the fluid cells float in. Blood pressure is the force of the circulating blood against the arterial walls. Systolic blood pressure is when the ventricles contract. Diastolic is when the ventricles relax. A pulse is felt when blood passes through an artery during systole. Peripheral pulses felt in the extremities. Central pulses are felt near the body's trunk. And these are the major pulse points that you need to be familiar with as EMTs. Carotid, femoral, brachial, radial, posterior tibial, dorsalis pedis. Cardiac output is the volume of blood that passes through the heart in 1 minute. Heart rate times volume of blood ejected with each contraction, which is the stroke volume, will give you cardiac output. So how fast the heart is beating and the amount of blood that is being ejected with each contraction will determine how effective cardiac output is. Perfusion is the constant flow of oxygenated blood to tissues. Requirements of good perfusion: the heart must be working effectively, there must be enough blood to circulate, the blood must have the components that are necessary, and the respiratory system must be working effectively. If perfusion fails, cellular and eventually patient death will occur. Now let's look at the pathophysiology. Chespian, also known as Angina Pectoris. So chest pain, you will see the term chest pain or you will see the term angina pectoris. It's the same thing, chest pain. The chest pain usually stems from ischemia. Ischemia is a lack of oxygen, right? So there's a lack of oxygen due to inadequate blood flow to an to an area of the heart. Ischemia leads to infarction. So if ischemia is not corrected, infarction will develop. Infarction is death. If the dead cells are not dealt with appropriately, or they minimize the expansion of the dead cells, then it will lead to what we call necrosis. So ischemia leads to infarction, infarction leads to necrosis. Necrosis means rotten tissue. So chest pain usually stems from ischemia, which is decreased blood flow. Ischemic heart disease involves a decreased blood flow to one or more portions of the heart. If blood flow is not restored, the tissue dies. Once the tissue starts to die, that is infarction, hence a myocardial infarction. We know this part already in terms of how this occurs. So you have atherosclerosis, which is a buildup of calcium and cholesterol in the arteries, and it causes narrowing of the diameter of the artery, which causes pressure to increase over time. If this fatty deposit is not dealt with, eventually it's gonna harden over time and become arteriosclerosis. And with the high blood pressure, it can tear off a piece of this plaque, which forms a clot in the vessel. Hence, the patient gets a myocardial infarction. A thromboembolism is a blood clot floating through the blood vessels. If a clot lodges in the coronary artery, the patient will get an acute myocardial infarction. Coronary artery disease is a leading cause of death in the United States. Factors that can be controlled or controllable AMI risk factors include cigarette smoking, high blood pressure, high cholesterol, high blood glucose level, lack of exercise, and obesity. Uncontrollable AMI risk factors would be old age, family history, atherosclerotic coronary artery disease, race, ethnicity, and being a male. Now, acute coronary syndrome. Acute coronary syndrome is caused by myocardial ischemia. So there are two conditions that fall under acute coronary syndrome. It can be angina pectoris, which is chest pain due to inadequate blood flow to an area of the heart, or it can be an acute myocardial infarction, which is a clot has been formed in one of the coronary vessels, which is cutting off blood flow to an area of the heart. So when you think about acute coronary syndrome and these conditions, you will treat them the same. So you're going to use the same protocol to treat angina pectoris and acute myocardial infarction. You're going to use the same protocol. Angina pectoris occurs when the heart's need for oxygen exceeds supply. So you can have stable angina, you can have pathologic angina. Now, what we call stable angina pectoris is a person has not been active for a while, and all of a sudden they decide that, okay, I need to start exercising, and on their first exercise routine, they go extreme. So they don't allow the body to gradually adjust. They start to push the body immediately. what is going to happen is the heart is not accustomed to that level of demand, so it won't be able to perform based on the activity that the person is carrying out. So because that activity demands a lot of blood flow, the heart is not used to that, so there is not enough blood flow coming to the heart to meet that demand. So once the blood flow that is required for that activity is insufficient, the patient will start to get chest pain. However, when this individual gets the chest pain and they go and sit down for 10-15 minutes, the pain subsides. So when they go and rest, or if they even take nitro, which might not be needed, but rest. Once they rest and the heart rate goes back down and it can get the amount of blood that is required, the pain subsides. That's what we call stable angina. Unstable angina is the person who has the clogged arteries. So the arteries are filled with cholesterol or fatty deposit or calcium, or it can be it has hardened, but there's something clogging up the artery. And whether they perform an extreme activity or not, they start to get chest pain because sometimes the arteries pinch shut, right? So they constrict too much and enough blood flow is not going to the heart because they are clogged up. And these individuals will now start to get chest pain, right? So whether they are active or inactive, and they may need medication to dilate the vessel to reduce that discomfort. You have a question, Mr. Jones?
Yes, sir. What type of angina is that called again?
Which one?
The one where the vessels are clogged with fatty deposits.
Not hearing you.
The type where the vessels are clogged with fatty deposits.
That would be unstable angina.
Okay, thank you, sir.
All right. All right, so angina pectoris occurs. You have a question, Mr. Duhaney?
Yeah, yes, sir. Can this like when the vessels are blocked, right? And the patient takes like medication to expand those vessels. Can that blockage break off and like go somewhere else and cause issues there?
No, because a patient that is having angina doesn't have a blockage, right? So that's the first thing that you need to understand. Regardless of the type of angina that a patient is having, it doesn't mean that the blood vessel is blocked. It means that the blood vessel is too narrow, right? So a patient who
Awesome.
has a block is having a heart attack. If you dilate the blood vessel for a patient who is having a heart attack, the pain doesn't go away. The blockage just goes further, right? So a patient who is having a heart attack, a vasodilator will not relieve that pain. A vasodilator will relieve the pain for angina. It doesn't relieve the pain of an MI. And that's a key thing to look for. So if you have a patient with chest pain, because both patients will present with chest pain, whether it's angina or a myocardial infarction, if you give the patient who is having an MI nitroglycerin, which is a vasodilator, it's not going to relieve the pain and discomfort. So the patient can complain of crushing or squeezing pain, and to be honest, you will hear the patient complain more of pressure, increased pressure, than you will hear them complaining of pain. So crushing or squeezing pain or pressure or discomfort does not usually lead to death or permanent heart damage, should be taken as a serious warning sign. Unstable angina in response to fewer stimuli than normal. I have already explained that, right? What unstable is and what stable is. Stable angina can be relieved by rest or nitroglycerin. Treat angina patients like AMI patients. So whether it's a chest pain or AMI patient, your treatment protocol is going to be the same. Oxygen, if it is necessary, but it's better to start on the low end for oxygen administration. Nitroglycerin, which is a vasodilator, if the blood pressure is not too low, and aspirin, and you would give aspirin before you consider nitroglycerin. And what would be the purpose of aspirin? Why would we need to give this patient aspirin? Go ahead, Miss Barnes. Is your mic working? Your mic not working. I'm not hearing you. So type in the chat. Anybody that have a mic that's working want to answer. Why do we need to give this patient aspirin? You people should be reviewing your pharmacology. Go ahead. Hold on, Mr. Jones. You have not been acknowledged. You haven't been acknowledged. You shouldn't be speaking. Yes, Miss Roxburgh, go ahead.
Yes, sir. Good morning. So we would want to give them aspirin to allow for easier flow of the blood. So we want it to not be so thick so it can flow easier.
Aspirin doesn't thin out your blood.
Well, I know. Well, I watched the thing yesterday, so I think what the video was saying is that it lubricates the platelets or something like that. More. I don't quite remember. I have to go back.
All right. Anybody else? So, even though you have heard the term used quite loosely in medicine that aspirin is a blood thinner, it is not a blood thinner. Yes, Mr. Doheny, go ahead.
Aspirin like break up blood clots and it prevents them as well. Like it helps to prevent blood clots and like
aspirin doesn't break.
Aspirin
doesn't break up blood clots. Doesn't break up blood clots.
It decreases the size of the blood clot.
Doesn't reduce the size of the blood clot either.
Okay.
Anybody else? Okay. All right, so you people need to read up your pharmacology. All right, go ahead, Mr. Facey, if your mic is working, and this is the last one I'll take. Go ahead. Not hearing you. All right, so I'm not hearing you. Have to move on now. All right. So aspirin can be given for a lot of things. It have can be given for fever. It has antipyretic properties. Can be given for inflammation. It has anti-inflammatory properties. It can be given for pain. But in EMS, the only reason for us administering aspirin to a patient is for its anti-platelet properties, right? So it has what we call anti-platelet properties. So if this, let me see if I can draw, if this is the clot in the vessel, when the patient takes aspirin, aspirin is going to bind to the platelets within the patient's body, and it will prevent platelets from sticking. So it's going to prevent platelets from sticking to the clot. So what aspirin is doing for the patient is preventing the clot from getting bigger. It does not reduce the size of the clot, and it does not remove the clot that is present. All it will do is prevent platelets from sticking to the clot to prevent it from getting bigger. And the antiplatelet properties of aspirin last up to 7 days. So these effects can last up to 7 days. So it does not thin the blood out. Aspirin does not change the viscosity of the blood. And as I say, you'll hear that said a lot in medicine. The only thing that can change the blood's viscosity is running an IV fluid that is not controlled in a patient with internal bleeding. So you have a patient that's bleeding externally or internally excessively, and you give IV fluid and it's not controlled and based on body weight, then the blood will start to look like Kool-Aid. That will dilute clotting factors and thin out the blood and change the viscosity of the blood. So that's that. So that would be the purpose of the aspirin for this patient. And once there is no contraindication, the aspirin should be given early. Oops. So AMI pain signals actual death of cells in the heart muscle. Once dead, cells cannot be revived, and time is muscle. So the patient is going to need to get to the hospital as soon as possible. Now, clot busting or thrombolytic drugs or angioplasty within the first few hours prevent further damage. So thrombolytics will break down clots. Angioplasty, all they're doing is going in, putting a stent in the vessel and trying to remove the clot that's there. Patient will require immediate transport. This is essential. Now, signs and symptoms of an AMI: weakness, nausea, sweating, pain, discomfort, or pressure. Pressure is very, very, very common. Lower jaw, arm, back, abdomen, or neck pain. So the pain can radiate to these areas. Irregular heartbeat and syncope or fainting. This is very common in your geriatric population. So the geriatric population might not be complaining of any pain or discomfort. All they have is some syncope and the heart rate is irregular, or they might be having just shortness of breath, dyspnea. Nausea and vomiting, pink, frothy sputum, sudden death. AMI pain differs from angina pain. So you need to be able to differentiate AMI pain from angina pain. So it is not always due to exertion. Angina can be as a result of exertion. AMI is not. AMI pain lasts 30 minutes to several hours. Angina Pectoris rarely exceeds 15 minutes. Not always relieved by rest or nitroglycerin. Rest or nitroglycerin will relieve angina pain, might not relieve the pain for an MI. AMI patients may not realize they are experiencing a heart attack. AMI and cardiac compromise physical findings. Patient, there will be fear, nausea, poor circulation, and sometimes the patient will tell you they feel like they are not going to survive or they feel like they are going to die. Fast or irregular or bradycardic pulse, decreased normal or elevated blood pressure. And if they have a low blood pressure, then you know you have cardiogenic shock developing. Normal or rapid and labored respirations. They can develop pulmonary edema if they start to go into left side heart failure. They will benefit from CPAP. Patients express feelings of impending doom. Now, this part you know, I have drilled this into your head. Some of you might not have absorbed it yet, but those of you who have, remember this. Once you have a patient that you suspect is having an acute myocardial infarction, you need to anticipate 3 things occurring. Sudden death within the first 2 to 4 hours, or 2 hours. It's going to occur more commonly in the first 2, resulting from cardiac arrest. They go into cardiac arrest, they are going to require early CPR, early defibrillation, early advanced cardiac life support, early definitive. They can develop cardiogenic shock, where the heart muscle is so damaged that it loses 40% of its cardiac output. They can develop congestive heart failure, which is right side dominant or left side dominant. They have right side dominant heart failure. Fluid accumulation will occur, back pressure will be created in the liver, distended neck veins, and the lower extremity. And it takes days for right side heart failure to develop. If it is left side dominant, then they get back pressure being created in the lungs and they develop pulmonary edema. This can occur within minutes to hours. So they can start having complications on the left side within minutes to hours because there is fluid in the alveoli that is affecting the exchange of oxygen and carbon dioxide. Oops. No, dysrhythmias, heart rhythm abnormalities can occur, and I will go more into this when I cover the ECG lecture, because me talking about premature ventricular contractions, you have no idea what that is if you cannot see it. And in a nutshell for now, a premature ventricular contraction simply means that the ventricle is trying to regulate the heartbeat. So you're seeing a premature beat from the ventricle. And if it is consistent, then the patient is going to go into cardiac arrest. Tachycardia, you already know. Bradycardia, you already know. Ventricular tachycardia is a rapid heartbeat that is coming from the ventricle. Because it is too fast, it is not sufficient to maintain cardiac output. With ventricular tachycardia, the patient can have a pulse or they cannot have a pulse. So a pulse might be present or a pulse is absent. If they're in ventricular tachycardia with no pulse, they require CPR and the use of a AED. So this is a rhythm that can be defibrillated. So there are two rhythms that we can use a AED for. The only two rhythms that can be defibrillated is pulseless ventricular tachycardia and ventricular fibrillation. And I've already explained what would be ventricular fibrillation. So defibrillation restores cardiac rhythms, it can save lives, initiate CPR until a defibrillator is available. Asystole is a flat line, and we see this a lot in the movies, right? So we see this a lot in movies. You see that flat line, and I've seen some shows where they're actually trying to shock a flat line. Once you see a flat line on your monitor, it means there is an absence of electrical activity. There's no current there. There's nothing to shock, right? And in real life, we call codes when we see asystole. So this is where we will call a code, right? This is where we pronounce the patient dead. And paramedics are allowed to do that now. EMTs, you would seek advice from your medical director, and your medical director would guide you in the field. But as a paramedic, we are currently allowed to pronounce once we see asystole or sustained PEA. So asystole is an absence of heart electrical activity. It reflects a long period of ischemia. Nearly all patients will die. It's a flat line. So you cannot shock that, regardless of what you see on the television. Next one. Come on. Oops. Okay, cardiogenic shock. Cardiogenic shock, often caused by heart attack. Heart lacks power to force enough blood through circulatory system. Inadequate oxygen to body tissues causes organs to malfunction, often caused by a heart attack. The heart lacks the power to pump. Recognize shock in its early stage and do what you need to do for the patient. Congestive heart failure often occurs a few days following a heart attack. So congestive heart failure cannot be an acute problem. Okay? So often occurs a few days following a heart attack. Increased heart rate and enlargement of left ventricle no longer make up for the decreased heart function. The lungs become congested with fluid, may cause dependent edema, which simply means that fluid is settling in the lower extremities, and the fluid that we're talking about is plasma. So it's plasma that is leaking out of the vessels or between the cells and tissues. Hypertensive emergency. Now, a systolic pressure greater than 180 millimeters of mercury. Now, a blood pressure reading doesn't define a hypertensive emergency. A patient can have a systolic of over 180 and they are not having a hypertensive emergency. So try not to get too caught up on numbers. You can use numbers as a marker, but at the end of the day, it is the patient presentation that will confirm that. So a hypertensive emergency is a very high blood pressure, definitely, that causes systematic changes. So the pressure is so high that it alters systematic functions. Sudden severe headache, strong bounding pulse, ringing in the ears with dizziness. So it alters systematic functions. So common symptoms: nausea, vomiting, dizziness, warm skin, dry or moist, nosebleed. Altered mental status would be one of the most significant ones. And of course, sudden pulmonary edema. The pressure can be so high that it creates back pressure on the left side. If untreated, the issue is the patient can get a hemorrhagic stroke, or they can get a dissecting aortic aneurysm. And any patient who has a systolic over, I would say over 60, 160. So at 160 or above, with a diastolic of 110 and above, is a patient that is at risk for stroke or a dissecting aortic aneurysm. That would be somebody that needs to see their doctor and get prescription for blood pressure controlling medication. Transport the patient quickly and safely. Consider ALS assistance. Aortic aneurysm is weakness in the wall of the aorta. It is susceptible to rupture. Dissecting aneurysm occurs when the inner layers of the aorta become separated. So the pressure is so high that it causes the wall of the aorta to start to split into two. And it's very unique. It's a very unique presentation in that this patient, so a patient with an aortic aneurysm, will have extreme pain immediately. So the pain is going to be severe from the onset, not like a myocardial infarction. A myocardial infarction, the pain gradually gets worse. Aortic aneurysm patient, the pain is going to be severe from the onset. They will often tell you that they feel it more to the posterior of the chest than the anterior. And they will describe that pain as a tearing sensation. So they're gonna describe it as something is ripped. They feel like something is being ripped apart or torn. Now, one of the unique findings for the patient with an aortic aneurysm is when you take the pulse. So when you hold the pulse is gonna feel different on the right side in comparison to the left side. And the blood pressure is going to be higher on the left side in comparison to the right side. Somebody's mic is on, mute that mic. So this table 16-1, what you look for the acute myocardial infarction and what you look for the dissecting aneurysm, pay close attention to that. Very important. Now, aortic aneurysm, signs and symptoms. Very sudden chest pain, comes on full force, different blood pressures. So the blood pressure on the right side will not be the same on the left. Transport patients quickly and safely. Now, patient assessment. Scene safety, ensure scene is safe, follow standard precautions. Nature of illness, obtain clues from dispatch, the scene, patient, family members, bystanders. Form a general impression of the patient and the environment when you get to your primary. If unresponsive and not breathing with no pulse, begin CPR, use your AED as soon as it is available. Airway and breathing, oxygen saturation less than 95%, apply oxygen with a non-rebreathing mask at 15 liters per minute. And what I will tell you for your cardiac chest pain patients, if their pulse ox reading is between 90 to 91, I would say 90 to 92%. If you're going to give them oxygen, start with low flow. Right? Start with your low flow if you're going to give them oxygen. Too much oxygen can cause further complications for these patients unless they're showing signs of hypoxia. Go easy with the high flow. It's better to start off with low flow. Not breathing or inadequate breathing, 100% oxygen with your BVM. If they have pulmonary edema, consider using a BVM and CPAP device. Circulation, check pulse, skin, capillary refill. Consider treatment for cardiogenic shock. Transport decision based on ability to stabilize life threats during the primary assessment. Transport in a stress relieving manner. And if you suspect MI, be careful with the use of your lights and sirens. And I would say no sirens for these patients. It can trigger dysrhythmias or arrhythmias in the patient. History taking, investigate the chief complaint, example, chest pain, difficulty breathing. Obtain a sample history from a responsive patient. Use your OPQRST. In your secondary assessment, physical examination, focus on cardiac and respiratory system, circulation, respiration. Vital signs, measure and record the patient's vital signs. If available, use your pulse oximetry. For your reassessment, reassess vital signs at least every 5 minutes or when patient's condition changes significantly. Sudden cardiac arrest is always a risk. If cardiac arrest occurs, perform CPR immediately until an AED is available. Reassess your interventions, provide rapid patient transport and communication and documentation. Now, emergency medical care for chest pain or chest discomfort. Ensure a proper position of comfort. Give oxygen if it is indicated. Be very vigilant with your oxygen administration. If the patient doesn't require any oxygen, don't give it. If they need oxygen, start on the lower end. We want a pulse ox at 93% or a little above that. Depending on protocol, prepare to administer low-dose aspirin, baby aspirin, and assist with prescribed nitroglycerin. Aspirin effects, it prevents blood clots from forming or getting bigger. 81 milligram chewable tablets, that's your baby aspirin. So they can get 4 81 milligram chewable tablets, or they can get 2 tablets, which is 162 milligrams, or they can get 4 tablets, which is 324 milligrams. And it should be non-enteric coated aspirin. So you give them the aspirin, tell them to chew and swallow. Nitroglycerin is available in many forms. It can be in pill form, it can be in spray form, it can be as a skin patch applied to the chest. It is a vasodilator. Mechanism of action, it relaxes the blood vessel walls, it increases blood flow and oxygen supply to the heart, and it decreases the workload of the heart and dilates blood vessels. Side effects, the patient will complain of a severe headache. There's going to be changes in the pulse rate. It's going to cause the blood pressure to drop. They will complain of a bitter taste unusual taste if it is potent. Now, because it can cause the blood pressure to fall, you need to know what the patient's blood pressure is before you give the aspirin. So if their systolic blood pressure is less than 100, do not give nitroglycerin. Right? Don't give it, because one of the side effects is it will cause the blood pressure to drop. And if it's already low, you're just going to drop it further, and that is going to, you're going to create cardiogenic shock in your patient. The patient has a head injury, we don't give nitro. If they are using erectile dysfunction drugs within 24 hours, Cialis, Levitra, sildenafil, Viagra, these medications, they have used it within 24 hours, we do not give nitroglycerin, because these erectile dysfunction medication they also have vasodilating effects, and it can potentiate the action of nitroglycerin. They can have a massive drop in their blood pressure. Maximum prescribed dose has already been given, which is usually 3 doses. So if they've already taken 3 doses of nitroglycerin, you can't give them anymore. Now, administering nitroglycerin, ensure the medication has not expired, nor was it contaminated. Ensure the medication is prescribed for the patient. Wear gloves. Now, cardiac monitoring. For an ECG to be reliable and useful, electrodes must be placed in consistent positions. Basic principles should be followed to minimize artifact in the signal. ECG tracing, that is the result of interference or artifact. Now, cardiac monitoring. The purpose of cardiac monitoring is to monitor a patient with a cardiac emergency or respiratory emergency, or any patient that is critical. So definitely your patient with a cardiac history and complications, you want to put them on a cardiac monitor. Patient with respiratory complications, definitely. Any patient that's critical, we want to get them on a cardiac monitor. Now, cardiac monitoring uses 4 or 5 electrodes. So let me get to it. So if you look over here on this diagram, there are 4 electrodes: white, black, green, red. When we're doing cardiac monitoring, this is the placement of the electrodes: upper right shoulder, left right shoulder, lower abdomen right, lower abdomen left. And sometimes you will see an electrode at the apex beat. So it can be 3 electrodes, it can be 4 electrodes, or it can be 5 electrodes. So that's the amount that is used for cardiac monitoring. Now, regardless of the amount of electrodes that is being used for cardiac monitoring, whether it's 3, 4, or 5, you can only look at 3 leads. So you can only look at 3 leads. So let me repeat that. Regardless of the amount of electrodes you are using for cardiac monitoring, it can only give you electrical capture for 3 leads: lead 1, lead 2, and lead 3. Now, the green electrode is the stabilizing electrode. So this is the electrode that stabilizes the current, or ground electrode as it's sometimes called. So that's cardiac monitoring. Now, because the cardiac monitoring gives you a limited view of the heart, if we want a better picture of what is going on, then the patient will require a 12-lead ECG. Now, even though it is 12 leads, we are only using 10 electrodes. So even though it's a 12-lead ECG, we are only using 10 electrodes. To get 12 leads, we have to augment the current. And I'll go into that more when I'm focusing specifically on the ECG. I don't want to go too deep into that now. So artifact is ECG tracing that is the result of interferences. If the lead is not placed properly, sometimes if you have your cell phone near the device, it can cause the lead to be printed out incorrectly. If the patient is moving around, if the electrode is not placed properly, so a lot of things can cause the ECG to be printed with artifact. So again, cardiac monitoring is for any patient with a cardiac history and complication that is within your care. Any patient with respiratory problems, you want to put them on a cardiac monitor. Any patient that you consider to be critical, we want them on a cardiac monitor. So the cardiac monitor monitors their heart activity, and it will go off or alarm if something changes. And if you're listening and observing the monitor, you will see if something changes as well. However, the cardiac monitoring gives you a limited view. So it's more of a dynamic view. You can print off a lead with cardiac monitoring, but you're not getting a full picture of the heart. If you want a full picture, then you would do a 12-lead ECG. Cardiac monitoring requires 4 or 5 electrodes. However, you can only look at 3 leads, 1, 2, and 3. So you'll only say lead 1, 2, and 3 with cardiac monitoring. With a 12-lead ECG, even though it's 12 leads, it's 10 electrodes. And the limb leads are augmented to get the 12. Now, guiding principles. May need to shave body hair, rub electrocyte with alcohol swab before application, attach electrodes to ECG cables before placement, confirm electrode placement. So the placement is very important, right, for a 12 lead. So with the 12 lead, you have your 4 limb, you have your 4 electrodes that you use for cardiac monitoring, and then you add 6 precardial chest leads, and they have to be placed properly. So V1 is 4th intercostal space on the right. V2 is also 4th intercostal space on the left, close to the sternum. So you put down V1 and V2. After you put down V1 and V2, then the next electrode you put would be V3, which is V4, which is the 5th intercostal space, right? Just below or under the nipple, depending on the type of patient you have. Now, once you put down V1, V2, and V4, V3 goes between V2 and V4. Then the next electrode, chest electrode that you put on the patient would be V6, which is mid-axillary fifth intercostal space. After you put down V6, V5 will go between V4 and V6 in the anterior axillary line. So it's anterior axillary. So the placement is extremely important. Give me a sec. My background is a bit noisy. Hold on a sec. All right. Right, so that's the placement. And to be honest, the placement is the easy part. So placement would be the easy part of doing an ECG. So it's very easy to learn how to place your electrodes and get your printout for your ECG. What is difficult to learn is what it represents. So you have to interpret the basics of the ECG and not rely on the machine to interpret the rhythm for you. So you must know what to look for. Connection went down. All right, sorry about that. Connection went a bit. Right, so you need to know what you're looking for. We're not gonna get into that right now. Just understand that if you're doing cardiac monitoring, it's 4 electrodes. If you're doing a 12-lead ECG, it is 10 electrodes. And when we're doing a 12-lead ECG, the electrodes on the shoulder are moved down to the forearm. And the electrodes that are on the abdomen are moved down to the lower extremities. That's when we're doing a 12-lead ECG. We'll get deeper into that as we go further. Now, once electrodes are in place, switch on the monitor, print a sample rhythm strip. If strip shows artifact, confirm electrodes are firmly applied and cable is plugged in. Now, heart surgeries and cardiac assistive devices. Many open heart operations have been performed in the last 30 years. Coronary artery bypass graft, chest foreleg blood vessel is sewn from the aorta to a coronary artery beyond the point of obstruction. So they're creating a different pathway for blood to flow. Percutaneous transluminal coronary angioplasty is a tiny balloon. It is inflated inside a narrowed coronary artery, and then they try and remove the clot. Now, patients who have had open heart procedures may or may not have long chest scars. Treat chest pain in a patient who has had any of these procedures the same as a patient who has never had heart surgery. Others will have an implanted cardiac pacemaker. So there are some patients in which their electrical conduction system of the heart doesn't work well, so they cannot pace their heart well without an outside stimulator. So they will have implanted pacemakers. Cardiac pacemakers maintain regular cardiac rhythm and rate. It delivers electrical impulses through wires in direct contact with the myocardium. implanted under heavy muscle or fold of skin in the upper left portion of the chest. Cardiac pacemakers, that's what it looks like. It's not very big. It's not a very big device. I would say it's about the size of making a circle with your index finger and your thumb. So if you make a circle with your index finger and your thumb, that would be the size of the estimated size of a cardiac pacemaker. This technology is very reliable. The pacemaker malfunction can cause syncope, dizziness, or weakness due to an excessively slow heart rate. Transport patients promptly. Some patients will have automatic implantable cardiac defibrillators, used by some patients who have survived cardiac arrest due to ventricular fibrillation. Monitor heart rhythm and shock as needed. Treat chest pain patients with these devices like other patients having an AMI. Electricity is low, it will not affect rescuers. Some have external defibrillator vests. These are things that you will see in first world systems. You're not going to see that out here. So a vest with a built-in monitoring electrodes and defibrillation pads worn by the patient attached to a monitor. Uses high energy shocks. Do not touch the patient. If device is worn, it is about to deliver a shock. Vest should remain in place while CPR is being performed unless it interferes with compressions. Some patients will have what is referred to as a left ventricular assist device. And I was quite fortunate to encounter a patient in the hospital when I was in Texas with this device. Now, this is a patient who is a candidate waiting on a heart transplant. So their heart basically doesn't work anymore. What the device does, so this device is basically circulating blood within their body, right? So it's like a mechanical heart for the patient. This patient will not have a pulse. So this is a patient in which you will not be able to feel a pulse. And when you listen to the patient's heart, you're not going to hear a heartbeat. You're going to hear a sound like a engine humming. So they don't have a heartbeat. And it's very, very interesting that this patient was one of the most upbeat persons I've ever met in my entire life. And basically, she was talking to me because she have a mechanical device. The day the power goes on that, or if she can't charge it in time, she wouldn't be talking at all, right? But she was quite upbeat and she could tell us a lot about the device that she had, and yeah, that's what it is. So a left ventricular assist device used to enhance the pumping of the left ventricle, may be pulsatile or continuous. The patient or family can tell you more about the device. Transport all supplies and battery packs with the patient. Now, cardiac arrest. The complete cessation of cardiac activity, absence of cardiac pulse, no breathing. Was terminal before CPR. External defibrillation were developed in the 1960s. So before the implementation of defibrillation devices, the death rate for cardiac arrest was quite high. Automated external defibrillator or defibrillation. It analyzes electrical signals from the heart and identifies two rhythms. It can pick up ventricular fibrillation and it can pick up pulseless ventricular tachycardia, the newer ones. Administer shock to heart when needed. AED model. So you need to be familiar with the type of AED that you carry on your unit, right? Be very familiar with the AED. You need to check it regular. Make sure that you have backup battery devices. So AED models all require some operator interaction. Most have a computer voice synthesizer advising steps to take. Most are semi-automated. So I always say it's foolproof. All you need to do is turn on the AED and follow the instructions. So it's foolproof. Turn on the AED, follow the instructions. The mistakes that persons make is they turn on the AED and they are going ahead of the device. Turn on the AED, follow the instructions. Don't preempt the device. Advantages of AED use: quick delivery of shock, easy to operate. ALS providers do not need to be on scene. Remote adhesive pad, safe to use. Larger pad area equal more efficient shocks. Other considerations: though all cardiac arrest patients should be analyzed, not all will require shock. So the AED can only detect shockable rhythms. All patients in cardiac arrest should be analyzed with an AED. Asystole or flatline equals no electrical activity. Your patient can also have what is called pulseless electrical activity. So they have an organized rhythm. So you can see organized electrical rhythm, but there is no pulse. That's pulseless electrical activity. Early defibrillation. Few cardiac arrest patients survive outside of hospital without rapid sequence of events. Chain of survival: early recognition, early activation of EMS, immediate bystander CPR, which is very lacking in Jamaica, rapid defibrillation, which is very lacking in Jamaica, basic and advanced EMS. We have the basic is weak. So the CPR that we are doing as pre-hospital providers is very, very inefficient in Jamaica. ALS and post-arrest care. So everything needs to be early. So early defibrillation. CPR prolongs period during which defibrillation can be effective. Has resuscitated patients with cardiac arrest from ventricular fibrillation. Non-traditional first responders are being trained in AED use. The more people you have trained, the better. ALS and post-arrest care. Continue ventilation, maintain oxygen saturation, assure blood pressure is greater than 90, maintain glucose levels, rapid transport. So this is the goal of ALS. This is what we want to do if we get back a pulse, right? EMTs, your responsibility is to do high quality CPR with the use of a AED. If we get back a pulse, then we can maintain ventilation, pulse ox, blood pressure, glucose. And if your CPR is high quality, then I can build on that, or ALS can build on that with ACLS procedures. Integrating the AED and CPR. Work the AED and CPR in sequence. Do not touch the patient during analysis and defibrillation. CPR must stop while AED performs its job. So once the AED is available, whoever comes with the AED is in charge. So anytime that person wants CPR to stop, it needs to stop. Nobody should be touching the patient when the device is analyzing. If someone is touching the patient, it's going to pick up their rhythm. Nobody should be touching the patient, and the oxygen should be off the patient when you're going to deliver a shock. somebody's touching the patient, you're going to have more than one patient to deal with. AED maintenance is important. Maintain as manufacturer recommends. Read the operator's manual, document AED failure, check equipment daily, and at the beginning of shift, ask manufacturer for maintenance checklist. Report AED failures to manufacturers and U.S. Food and Drug Administration. Follow local protocol for notifying. Medical direction should approve written protocols for AED use. Continuing education with skill competency review is generally required for EMS providers. Emergency medical care for cardiac arrest. Preparation. Make sure electricity injures no one. Do not defibrillate patients in pooled water. Do not defibrillate patients touching metal. Carefully remove nitroglycerin patch and wipe with a dry towel before shocking. Shave hairy chest to increase conductivity. Determine NOI or MOI. Perform spinal immobilization for trauma patients if required. Call for ALS assistance if it is a part of your EMS response systems. Begin chest compressions and attach AED as soon as it is available with witnessed cardiac arrest. Follow local protocol for patient care after AED use. After AED protocol is completed, one of the following is likely: pulse regained, no pulse regained, and no shock advised. No pulse regained and shock advised. Wait for ALS and continue shocks and CPR unseen. If ALS is not responding and protocols agree, begin transport when the patient regains a pulse. 6 to 9 shocks are delivered. AED gives 3 consecutive messages every 2 minutes of CPR advising no shock. So let your protocol guide when you transport. Cardiac arrest during transport. So if we have a patient and the patient goes into cardiac arrest while we're transporting the patient, you cannot shock a patient in a moving ambulance. Stop the vehicle, begin CPR. If AED is not immediately available, call for ALS support, analyze the rhythm, deliver shock if indicated, and resume CPR. Continue resuscitation per local protocol. Coordination with ALS personnel. If AED is available, do not wait for ALS. Notify ALS of cardiac arrest. Do not delay defibrillation. Follow local protocols for coordination. Now, management of return of spontaneous circulation. And this doesn't mean that your patient has survived. The patient can get spontaneous return of circulation and go back into cardiac arrest, or they don't recover fully. Monitor for respiration, provide oxygen via BVM at 10 to 12 breaths per minute. Maintain oxygen saturation between 95 to 99%. Assess blood pressure. See if the patient can follow simple commands. Immediately begin CPR if ALS is not en route per local protocol. And that would be the end of the cardiovascular emergencies. Now, we will break. Let's break. We're going to break.